Hello, I'm Audrey Foncam, a third-year IM resident at Woodstock Kennestone, presenting on an unusual demonstration of hematologic complexities associated with severe vitamin B12 deficiency. My learning objectives are number 1, recognizing vitamin B12 deficiency as an unusual cause of hemolytic anemia and pancytopenia, and number 2, distinguishing different mechanisms of hemolysis in vitamin B12 deficiency. Vitamin B12 deficiency, which is a level of less than 200 picograms per milliliter, presents with a wide spectrum of hematologic and neurological symptoms and findings that include tingling, pancytopenia, fatigue, etc., representing a case of severe hemolytic anemia and pancytopenia from B12 deficiency. We have a 60-year-old female with hypothyroidism, family history of pernicious anemia, but no personal history of anemia, who presented with a 2-week history of exertional dyspnea and fatigue after her PCP noted her hemoglobin to be 7.6. She endorsed other vague symptoms but denied an intentional weight loss, active bleeding, recent illness, new medications, etc. Her last colonoscopy in 2019 was unremarkable. Her physical exam was also unremarkable. Lab findings included a white blood cell count of 2.39, with an absolute neutrophil count of 1.05, MCV of 121.8, and platelet count of 96. TSH was 10, with a free T4 of 1.11. Serum iron studies also showed a ferritin level of 297. LDH was elevated at close to 2,000, haptoglobin was undetectable, retic count was 2.27, total bilirubin was 2.7, and indirect bilirubin was 2.3, suggestive of intravascular hemolysis. Vitamin B12 was less than 150, however, patient did not have any history of malabsorption or prior GI surgeries. Direct antiglobulin test was negative, erythropoietin was appropriately elevated at 45, serum protein electrophoresis and folate level were normal. She received 1 unit of blood, was started on folic acid and B12 supplements. A CT of the abdomen and pelvis was negative for hepatosplenomegaly or lymphadenopathy. Her pancytopenia worsened, with symptoms and lab values improved with B12 replacement. Bone marrow biopsy and aspirate, as shown in figures A, B, and C, revealed a hepatocellular bone marrow with megaloblastoid erythromaturation, megakaryocytic hyperplasia with small forms, erythrohyperplasia, and inadequate hematopoiesis, with no evidence of dysplastic changes or clonal lymphoproliferative disorder, all suggesting a non-immune-mediated hemolytic anemia compatible with vitamin B12 deficiency. Phage studies, cytogenetics, and next-generation sequencing were normal, ruling out a myeloproliferative disorder and MDS. Surveillance in 3 months was recommended. So now, we'll proceed to the discussion and conclusion portion of this presentation. Hemolytic anemia, as a sequela of B12 deficiency, is rarely discussed because patients seldom develop it as a complication. It occurs from either intramedullary mechanism or extramedullary process, the latter of which results in the formation of schistocytes. Immune-mediated hemolytic anemia involves the presence of antibodies detected by the direct antiglobulin test. This patient had a low haptoglobin, elevated LDH, elevated indirect bilirubin, no schistocytes, and negative direct antiglobulin test, suggestive of non-immune intramedullary hemolysis. High clinical suspicion for this phenomenon is needed to diagnose it and treat it appropriately. Pancytopenia, as an initial presentation of B12 deficiency, is also rare, but most likely stems from the interference of DNA synthesis, resulting in giant megakaryocytes on bone marrow biopsy. The macrocytosis and normal folate suggest B12 deficiency rather than other causes of anemia, like hypothyroidism and MDS. And because just having a low vitamin B12 is not sensitive, having elevated homocysteine and methylmalonic acid levels is helpful for confirmation of deficiency. Adequate B12 replacement therapy will normalize these values in blood counts. With a suspicion that pernicious anemia is the cause of this patient's B12 deficiency, additional workup, including antiparietal cell antibody, and a complete GI evaluation are in progress. The rarity of this condition provides the reason as to why it is so infrequently described in literature. This concludes my presentation. Below are the references. Thank you for your time.